So the GLOW study is the first phase 3 study where the combination of Ibrutinib and Venetoclax was compared with a standard arm, and standard arm was chlorambucil obinutuzumab, which is in maybe less in the US now because most patients will use maybe Ibrutinib continuously, but in many countries in Europe it's still the number one treatment for elderly, less fit patients with CLL. So it's a head-to-head comparison where the treatment with the chlorambucil obinutuzumab is standard 6 months, while this was longer. This was a little bit over a year of ibrutinib plus venetoclax treatments. And what's important to discuss is that the way you give those drugs, because the disadvantage of venetoclax is that you have this high risk of tumor lysis because it's so effectively killing cells in the peripheral blood that you can have tumor lysis problems. But in the design of the GLOW study, which was the same as the Captivate study, which is a phase 2 study looking at the same regimen, but then for younger fit patients, is that patient got a lead-in of ibrutinib for 3 months, effectively debulking pretty much all patients. And then the combination was started with venetoclax and ibrutinib. Yeah, so the primary endpoint was progression-free survival. That was I showed that data at EHA, but what we now show is more emphasis on undetectable MRD. So we didn't discuss this yet, but undetectable MRD, at least for chemoimmunotherapy and for venetoclax plus antibody combinations, is a very good surrogate marker for progression-free survival. And the detection limit was always set at 10 to the minus 4, although you can measure deeper now. But if you are below 10 to the minus 4, so if you can detect less than one leukemia cell in a total of 10,000 of normal cells, then you are called officially undetectable MRD. So what we showed already in the summer conference at EHA was that the progression-free survival was much better with a very good hazard ratio of the study arm. But what we now showed is that also if you look to this MRD and specifically MRD kinetics, it's actually much better. So you have a very much improved number of patients getting into an undetectable MRD state. But that's one thing, but that's important. But maybe what's for me more striking was that after stopping of treatment, so we have MRD measurements 3 months after stopping and also 12 months after stopping. And what you can see is that the sustainability of the MRD, regardless at what level you are, low positive or negative or high positive, most patients with chlorambucil obinutuzumab 12 months after stopping, they move their MRD up to higher levels, meaning that it's kind of a prerequisite for PFS soon. But almost all patients or most patients in the study arm remained at the MRD levels over time, showing actually that it's not only a deeper MRD, but maybe more clinically important is that the MRD levels were much more sustainable also after stopping the treatment.